Hi everybody, and welcome to the RACGP National Webinar Series. My name is Dr. Ronald McCoy. I'm the Senior Education Strategy Advisor at the RACGP. Well, I'd like to begin this evening's webinar by acknowledging the traditional owners of the respective lands on which we're meeting today. And I'd like to pay my respects to the elders, past and present. I would also like to acknowledge any Aboriginal and Torres Strait Islander people present this evening. Okay, so before starting, I'd like to run through some features to make sure you can interact throughout the webinar. You should be able to see the control panel. It's like the image on the right of your screen. If you can only see a few icons, like the image on the left, please click on the red arrow to open the rest of the control panel. The control panel provides you with tools to select your audio options, and there's also a place to ask questions during the webinar. Here's a few tips and tricks that's worthwhile to know about throughout the webinar. You can send questions throughout the entire webinar. We've allowed half an hour of questions and answers at the end, but we may also be able to clarify particular points during the presentation if needed. So if they're relevant to the presentation at that time, I'll try and bring them up at that time. Otherwise, I'll save some questions until the end. We may not have time to get to all questions, but we'll endeavour to answer as many as possible. So to test this feature, please click where it says enter a question for staff and type in where you are located today and press send. So we want to see where you are. So just try that now. So where it says enter a question for staff, type in where you are today. Let's see what's happening. Oh, great. What's happening? Sydney, Devonport, Victoria, Lindfield, Bangor, Warwick, Queensland, all over. Adelaide, Brisbane, Lithgow. Wow, lots of places. It's fantastic. Well, it looks like you've got the idea of that. Oh, some remote places too, rural areas, which are great to see. Wow, so it's wonderful that people are from all over. And someone says they're stuck in the UK. So welcome and extra brownie points for attending the webinar this evening. This is fantastic. So I'm just showing our specialist where everyone comes from. So it's fantastic. Northern Territory too, that's really important. Fantastic. Okay. All right, so I think we'll one of the features that we can do during this webinar is that we can do poll tests. So we're going to practice now, and you should now, I think a poll should be coming up on your screen, and the question is, can you see it? You can see the poll there, and it says, do you know where to locate the Australian STI Management Guidelines? So you can see some responses there. And you can select your response and press submit. It's okay if you don't know where they are. That's fine, because by the end of this session you will know. So we're just testing the feature. So that's fantastic. Oh, I see. That's hiding behind something. Oh, great.
%.
Oh, okay. Oh, I see.
Know where the guidelines. That's pretty amazing.
That's very impressive. 63% of people of attendees know where the guidelines are. That's pretty fantastic. All right, so you're closing the poll. You close that and you share that. Great. All right, so just before we start, I'm going to just if you've entered your RSCGP number when registering, stay for the whole webinar and complete. And if you complete the survey, you'll receive 3 Category 2 points. And now that we can all interact, let's get started. So this webinar is proudly supported by the Australian Society of HIV Medicine for Viral Hepatitis and Sexual Health Medicine, so ASHM. And tonight's webinar is on STI testing in general practice, exploring the use of the Australian Sexually Transmissible Infection Management Guidelines. This webinar will explore the use of the Australian Sexually Transmissible Infections Management Guidelines, and it's in order to incorporate STI testing into routine general practice. The session will cover screening of asymptomatic individuals, recent updates to treatment and management, and emerging trends in epidemiology. And I'd like to introduce our presenter for tonight's webinar, Dr. Nicholas Medlin. Nick is a sexual health physician at Melbourne Sexual Health Centre and Royal Melbourne Hospital. He has 20 years of clinical experience in HIV medicine and HIV program delivery, oversight and management, including international aid programs in Vietnam as a care and treatment program chief, US Centers for Disease Control. Yeah, is that right? Wow, that's a mouthful. And in research, it's very incredibly impressive. In research, he's also been assistant director for clinical research at HIV NAT, which you'll explain what that is, and is currently an NHMSC research fellow at the Kirby Institute and University of New South Wales. So don't forget to put your questions in as we go to, and over to you, Nick.
Great, thank you, Ron, and thank you for the nearly couple of hundred people so far who've logged in to watch our webinar tonight. I'd also like to acknowledge the traditional owners of the land that we're meeting on today and pay my respect to Aboriginal and Torres Strait Elders past, present and future. Here's my conflict of interest statement. So as Ron mentioned, we're going to tonight focus on the Australian STI Management Guidelines. Now, I could easily run a 3-day seminar on the Australian STI Management Guidelines, so we've had to pick a few really topical, important key areas to focus on tonight, and they're largely going to be syphilis and gonorrhea, and a little bit more about general STI screenings and Mycoplasma genitalium. Again, this is a poll at the moment here. Just have you used or do you use the Australian STI Management Guidelines in your practice?
So you can select yes, no, or I
yes,
don't
no, I don't know. And we've got our responses coming through, and about currently about 75%, 80% say yes, they do. So that's great. We've clearly got an audience which is already familiar with the available resources, and if you use the guidelines, you're familiar with STI management in principles in Australia. 80% yes, very impressive. So here's a snapshot of the main page of the Australian STI Management Guidelines. If you've got a set of bookmarks on your web browser at work, you can bookmark stiguidelines.org.au. Also, if you enter STI Management Guidelines or Australian STI Guidelines in a Google search, this will most likely come up as your as your first hit. And you'll see there we've got information on asymptomatic checkup, on particular STIs, particular presentations, discharge, pain, etc., special populations, and then some links to the latest resources. So I invite you either tonight, while you've, if there's a bit of a slow patch and you're getting a bit bored with listening to me, maybe you explore the guidelines for a couple of minutes and come back, or look them up on your computer next time you're at work. So one of the main reasons I'm here talking to you today, and why we've got a renewed influence in STIs in Australia, is that there have been important changes in the epidemiology of sexually transmitted infections in Australia that change the way we screen, test and manage these conditions. I saw that there are quite a lot of people who entered Northern Territory and South Australia and Western Australia locations. You may be, and I'm sure there's some from North Queensland, you may be familiar with epidemics of syphilis that have occurred in those areas, but actually we've got some Australia-wide changes in the epidemiology of STIs. So here we are just looking at the commonest STIs, and tonight I'll just remind you that we're focusing on bacterial STIs. So I'm not really discussing HIV or viral STIs. We're talking about the bacterial STIs or curable STIs. There are 28,000 cases of gonorrhea notified in Australia in 2017. That was a 16% increase in 1 year. And I'll show you some graphs in a moment which will show that these increases have been continuing for some period of time and are really very marked. Even up until a few years ago, gonorrhea was predominantly an infection that you saw in gay men in urban centres, gay or bisexual men, in Aboriginal and Torres Strait Islander peoples in remote locations, and return travellers from Asia. That has changed, and we're seeing the largest increases of gonorrhea is in heterosexual men and in women. There are 100,000 cases of chlamydia in 2017, mostly effective young people. The chlamydia notification rates are perhaps a little bit more stable for the other STIs I'm going to be telling you about. Syphilis is really, I think, is the condition that we've seen the most alarming rises in notifications. Syphilis notifications are rising very rapidly. It's no longer restricted to men who have sex with men, return travellers in remote communities, increasing syphilis in heterosexuals. The largest increases, or the largest relative increases in syphilis, have occurred in women. And as I'll discuss with you later on, there's a high rate of transmission from mother to child, transplacental, and so we've seen a re-emergence of congenital syphilis in Australia. Rates of chlamydia, syphilis and gonorrhea in Aboriginal and Torres Strait Islander people are higher and are increasing more rapidly. So I'm going to show you a couple of these points in visual format. So this is a graph of infectious syphilis notification rates, or age-standardized rates, between 2008 and 2017. So the top line is in men, and the bottom line is in women. So even though the majority of infections are still in men, and when there's a great preponderance of men over women with sexually transmitted infections, that usually means that you've got increased rates in gay or bisexual men. If you look in this graph here, if you look back in 2010, you can see that really almost all the infections were in men, very little in women. It's gone up in every group, but the relative increase in women is the largest. We've seen an increase of at least 5 times over that 7 years. I haven't got on the graph here, but the ages of women most likely to be infected with syphilis are in their 20s and their 30s. And it's an absolute disaster if a pregnant woman gets syphilis or a woman with syphilis gets pregnant. And that's the real burden of disease that we're facing with syphilis at the moment. Same shape sort of graph here with gonorrhea. Again, men up the top, women down the bottom. Again, increases across the board. The actual relative increases are quite large in women also. You can actually see here, and I've got some 2018 state data in Victoria and New South Wales that we believe is reflected in the rest of the country for 2018. With gonorrhea is not only are rates of gonorrhea going up, but the rate at which gonorrhea is going up is going up. So we're getting a sort of a real ski jump shape on these notification rates. The last time rates of gonorrhea were this high was in the 60s and 70s. Before that, after the Second World War and after the First World War. And we do know that there's really almost literally nowhere that can stop. These rates can just keep on going up. unless we do something about it. And we'll be talking tonight about what we as a community of doctors and medical professionals can do about it. This is the same graph. Just keeping me on my toes here, I guess. So, we're going to talk now about some general principles of controlling STIs. And I just again wanted to start with a brief question about people, whether they find uncomfortable talking about STI screening with your patients. Yes, no, and sometimes. One's always tempted when answering a poll isn't to model what you'd like the answer to be in your ideal practice situation. So I very appreciate the people that have put sometimes down as the reason. There we are. So 41% sometimes, 50%. So starting a conversation about STI screening, firstly I'd mention that a sexual history would be considered, or taking and recording a sexual history would be considered best practice. It's frequently not done all that well and not documented all that well. It can be done quite quickly. Clearly, opportunistically, if there's some aspect of sexual health, urogenital health, it's usually an easy point to start a conversation about sexual health or STI screening. Certainly as a part of a reproductive health consultation. In fact, we have very good data to suggest that people who are at risk of STIs are expecting to be asked about their sexual history and their sexual behaviour, that most of the anxiety relies with the practitioner. And certainly any patient who requests any sort of checkup for STIs. And it's quite reasonable to say, in terms of a sexual history, people, for example, you can ask a question something like, have you had any new sexual partners? Are your partners men, women, or both? Do you mind if we do some STI tests today? The acronym STI is very well known in the community, particularly with younger people. And actually, you can just usually dive in and say, can we add some STI tests to your checks today? Key points to remember about sexual health. You mentioned, you'll notice before I said, have you had a new sexual partner recently? It's important in your language to try to avoid making assumptions about the gender of the partner. Terms like gay or having sex with other men can be used as a lead to help your patients answer your questions honestly. There are some points that we want, some words that we try to avoid. Words like prostitute are often have considered to be judgmental terms and can inhibit the sexual history and the recording the accurate information. It's important that you assure your patients that any information is confidential.
Someone has made a point, Nick. They've said that they ask all patients coming in for contraceptive advice about it's a good opportunity to discuss STI screening and also for things like cervical screening. So
yeah, so I think a prescription for the pill. Any discussion about contraception, I think any discussion that involves a patient's genital or urinary tract, it's reasonable to have a discussion about STIs. We've got a risk situation in Australia with the wonderful new cervical screening guidelines. Particularly younger women are going to be having less frequent cervical screening tests. So we're going to need to look for other hooks to have discussions, particularly with young women, so that the rates of screening for STIs doesn't in fact fall. Priority populations, so these are people that are known to either require more frequent STI testing, more likely to have an STI, or more likely to have an STI that's not diagnosed. And these are for different reasons. Aboriginal and Torres Strait Island peoples are much more likely to have an STI, and that's because they and their sexual partners are less likely to attend medical care and less likely to have been tested and less likely to have been treated. So that's an access to health services issue. The data doesn't support a difference in sexual behaviour. For young people, it's a combination. Young people are more likely to have STIs because they get checked, they go to the doctor less often, and they are somewhat more sexually active. Men who have sex with men, frequently the testing's not done correctly, and men who have sex with men do tend to have more frequent STIs. But there's also an anatomical issue with some STIs, in particular gonorrhea, chlamydia, are more likely to be asymptomatic in men who have sex with men. So these are all populations that if you can identify in your patients, that you can offer them more frequent STI testing. So what does an STI test involve? You should be able to select this or select an order set in whatever practice software you're ordering. A full STI test. So a patient says, doctor, I'd like to have an STI test. I've got a new partner. I'm in a new relationship. That would involve a blood test for HIV, syphilis, and hepatitis B, unless you've previously tested them and documented their vaccination status. Once you've documented the hepatitis B status, you don't need to do it on multiple occasions. Then your patient needs to be screened for gonorrhea and chlamydia. For a woman, that can be a vaginal or cervical swab, particularly if you're doing an examination or a cervical screening test, or a first pass urine in women is an acceptable screening test for gonorrhea and chlamydia. For heterosexual men, it's a first pass urine. For men who have sex with men, 3 sites need to be tested. You need a first pass urine, an anal swab, and a throat swab. Now, I've got little asterisks there. All of these ones can be self-collected. So I'm not prepared to ask somebody else to do what I wouldn't be prepared to do myself. Nobody wants to spend half their day swabbing people's anuses. Your patients are quite capable of finding their own anus in the bathroom under instructions from the collecting nurse. So the next swab here, and when you get the copy of this presentation, and at the end of the presentation, there's a link to the STIPU New South Wales Health Guidelines. Either you, if you're collecting your own specimens, or the practice nurse or the pathology collecting nurse can very easily instruct patients how to do their own vaginal or anal swabs while they're in the bathroom doing the first pass urine. It's important to do those 3 site tests because out of the 3 tests, the one that's most likely to be positive is the anal swab. The one that's least likely to be positive is the first pass urine. And for gay and bisexual men, the test that's most frequently done is the first pass urine, and the other 2 are often forgotten. Got another poll. So your patient comes in and tells you that they have received a text message from a sexual partner that they'd met in the recent weeks who've said that they've been diagnosed with chlamydia. What would you do in this situation? A, test them and wait for the results. B, test and treat before results. C, just give them treatment. D, nothing if the patient doesn't have any symptoms. Very impressive, massively high correct answer. So most of our guidelines will recommend testing and treatment before results. Chlamydia, and today I'll be talking to you about gonorrhea and syphilis, early syphilis, are incredibly infectious in the early stages. And the positivity rates in people who are sexual contacts is very high and certainly justifies presumptive treatment unless there's a reason why you don't think it's necessary. So a brief overview of chlamydia. Just to remind you, this is a bacterial infection of mucosal membranes caused by Chlamydia trachomatis. It's usually sexually transmitted, very frequently causes asymptomatic infection in the pharynx, anorectal infection in gay and bisexual men, can cause asymptomatic cervical infection. It's an important cause of pelvic inflammatory disease, and particularly with reinfection over time, is an important cause of infertility and then ectopic pregnancy, which is where the burden of disease lies with chlamydia, is reinfection, infertility and ectopic pregnancy. Asymptomatic infection can persist for months or years. Urethritis in men is usually mild. Symptoms may be transient. Men are great non-presenters when they have mild symptoms, and often reassured when the mild symptoms resolve. Vaginal discharge in women may be mild, and symptoms may be transient. So again, this is a tip of the iceberg scenario where the vast majority of patients don't have symptoms. Diagnosis of chlamydia is through a NAT test from the sites that I've mentioned to you before. Almost all labs will automatically do a chlamydia and gonorrhea test on the same specimen. For GPs who are ordering, the labs on the whole will do all of those 3-site testing, will do what appropriate coning for the billing of the tests. The 3-site testing in men who have sex with men is very important. And here is the management for uncomplicated infection. A week of doxycycline clearly can't be given in pregnant women. Azithromycin 1 gram stat, and a longer infection in symptomatic anorectal infection in gay men. Sorry, a longer course of treatment. These pages, you'll see this here is a direct cut and paste out of the Australian STI Management Guidelines. We have fairly similar follow-up recommendations for most bacterial STIs. We recommend the patient abstain from sex for 7 days. There's a high rate of cure. Patients can resume sexual activity in 7 days. These are notifiable conditions. Partners need to be notified, and I'm going to talk to you at the end of the presentation about how people can do that. It's a good idea to retest the patient at some point. It's not so much looking at treatment failure, but they have very high rates of reinfection.
Yep. I've got a couple of questions.
Yes.
This point. So a few people, someone's asked that if a patient's had sexual contact with someone with chlamydia, when will those tests become positive? Like how long you just test? When would you test? Straight away?
So yeah, straight away. So within a few days, actually. Yeah. Usually, these are antigen tests or RNA DNA tests. So they're looking for the presence of the organism, not like an antibody test that can take a couple of weeks.
Yeah. And there was another question that said, would you recommend a throat swab for females who participate in oral sex?
Yeah, so we just don't have the data there. Yes. on that group, so we're not in a position to make screening recommendations either for throat swabs in women who participate in oral sex. We have been doing it in sex workers, and we haven't got recommendations around anal swabs in women either.
Okay, thanks.
So we're going to move on now to syphilis, which I'm going to really spend most of the presentation on. patient presents with a solitary painless lesion on their penis and you decide to test for syphilis. Which test would you do? Serology, a swab of the lesion, serology and swab of the lesion, or dark field microscopy? I'm not sure there's anything I could teach this audience. Wow, very impressive. I think actually A or C would have been correct. C, I guess, is the advanced STI management correct answer. Serology would have been sufficient. So syphilis is a serious systemic disseminated bacterial infection. And we know now, because we're seeing so much of syphilis, we know a lot more about it than we did 10 or 15 years ago. It is incredibly infectious in the early weeks to months of infection. Sexual transmission occurs with inoculation at genital and extragenital sites. It can be oral, anal, or vaginal sex. It's got this particular unusually shaped spirochete. It has a coating on it which allows it to evade immune control. Some people call it a stealth organism, which is why you can have such disseminated infection with only mild systemic symptoms. And it has an unusual motility that allows it to get into extravascular in the central nervous system and across the placenta. There are different stages that we all would have learnt about at medical school. The classic primary, secondary, tertiary classification. I'm just going to talk a little bit about primary and secondary mostly today. Primary, this occurs at the point of inoculation. So if the person had contact with the spirochete at the cervix, rectum, mouth, penis, wherever it is, that's where they get a little lesion. It occurs about sort of 2 to 3 weeks after contact. The classic textbook primary lesion, or chancre, is a solitary painless lesion. But they can be painful and they can be multiple. So this is just a sort of a typical or a textbook presentation. Any sort of ulcer or genital lesions can be a primary syphilis lesion. Frequently can go unnoticed, particularly if it's anorectal or in the vagina or in the cervix. So these are pictures. You sign up for an STI course, you're going to get some nasty pictures at some point, aren't you? So top left, we've got a very typical chancre, and I think pretty much all of us would go thinking about syphilis if we saw that. Again, middle top on the right, 2 penile shaft ulcers. We've got possibly, on the right, we've got somebody in their, under their lip with a chancre. Bottom left, we've got a primary syphilis lesion that looks a lot like an anal fissure. I think plenty of us might think that's an anal fissure. The penile lesion in the bottom, middle of the bottom, again, it's non-ulcerated. Again, it's a primary syphilis lesion. And the one on the bottom right is an intrameatal lesion that, unless you're able to examine it carefully, you might not actually see an ulcer at all. These are all primary syphilis lesions. I'm giving you examples of sort of typical looking lesions. It's actually clinically not critical to distinguish primary and secondary. I've seen a lot of cases of syphilis. Sometimes I can tell the difference, sometimes I can't. It doesn't matter so much. I'm just letting you know the range of possible clinical manifestations. So secondary syphilis, this is dissemination. So primary is an infection at the point of inoculation. Secondary is when the patient gets disseminated. They may get systemic symptoms: fever, headache, malaise, lymphadenopathy. Tends to be fairly mild. which, as I said, is remarkable given that the patient has got a disseminated bacterial infection. Most other disseminated bacterial infections, the patient is very acutely unwell. Often causes a rash at this point. It's often generalised, classically can affect soles and palms. Often not typical. I think one thing that we've learned about syphilis is that the early research in the classic textbook discussions are often not always seen. They've got a wider range of clinical manifestations. It happens a bit later. It's very frequently misdiagnosed. And very concerningly, about 3% of cases of secondary syphilis have some neurological or cranial nerve involvement. The eyes, the optic nerves, the auditory nerves, balance, severe headaches, or meningitis. And in the beginning, I told you that in Australia in 2017 there were, sorry, I'm just flicking back to my printouts of the slides, there were, actually I haven't got numbers, we're definitely into the thousands of cases of syphilis in Australia every year, and you can see that at 3% we're talking about a fairly common occurrence, and I've heard that from a eye and ear hospital in an inner capital city location in Australia, the commonest cause of admission was ocular syphilis. So these cases, this is secondary syphilis. Now these things, I think, on the whole, you would probably be less likely to pick a secondary syphilis. The top left rash, the top second from the left rash, I don't think any of us would necessarily jump to a diagnosis of syphilis if we saw that. The palmar rash, the rash on the sole of the feet, a textbook syphilis rash involves the palms, so you might involve that. Again, the one on the top right, on the lower limb, I don't think you would pick that as syphilis. And the three down the bottom left are all genital lesions, which if you knew syphilis, you might recognise it, but if you didn't, you wouldn't necessarily. What all these pictures have in common are some sort of genital skin manifestation or some sort of rash which isn't immediately explainable by another diagnosis. And if there's a clinical take-home point you take home from this presentation, it would be beware a patient in a sexually active age range with a rash, particularly a rash where you don't immediately know what's causing it. So if there's something about the rash that doesn't quite add up, really please test your patient for syphilis. It's easy to miss and it's embarrassing to miss. If your patient has any sort of genital manifestation of the skin, they really do need to have syphilis excluded. It's severe if it's not diagnosed and treated, and it's curable. Some more secondary syphilis rashes. Again, the genital ones, so the top left and top right are both scrotum. The middle one is obviously under the foreskin and the penis, and the middle down the bottom. The one on the right, bottom right and bottom left, I really don't think anyone would come to a diagnosis of syphilis. So I'm just wanting to impress upon you the range of skin manifestations and how important it is to be thinking about syphilis when you see rashes. And this is particularly condyloma lata, which is a particular manifestation of secondary syphilis. Syphilis organism seems to like the slightly cooler skin and the mucous membranes, so it tends to gravitate back to the genital areas, which probably explains excess in transmission. It gets inoculated at the genital area, then it comes back. These lesions are very rich in spirochetes. Mucus patches, this one on the tongue, this one on the anus. Again, very infectious. Scalp and neck, again, unusual rashes in somebody of a sexually active age. most people working in sexual health have got a embarrassing, I missed syphilis because I thought it was this or that. It's a fairly, it's a striking experience when it happens. Rather than diagnosing primary versus secondary, what probably is more important is to try to determine how long somebody's had syphilis. Early latent versus late latent. Early latent is recent infection less than 2 years. Late latent is infection less than 2 years. Latent syphilis is just a term we use for anybody with no symptoms. Just a reminder that transplacental transmission occurs very easily with syphilis, resulting in stillbirth, fetal loss, preterm birth, neonatal death, and low birth weight. Congenital infection, the infant can be infected in utero or postpartum. The infection may appear uninfected. If the infant is infected and is not diagnosed or treated, very high rates of neurological and other disabilities. So clearly, a young woman with syphilis who gets pregnant or a pregnant woman who gets syphilis is an absolute disaster in terms of pregnancy outcomes. And what we're trying to do here is to make you aware of this rising health issue in Australia. We've got guidelines in Australia, in addition to first trimester screening, to do third trimester screening if there's some high risk. And in outbreak areas that I see some of you are calling in from, we've got these 5 points of testing in congenital syphilis. The important issue is the prevention of congenital syphilis, and that is to increase testing in sexually active women and heterosexual men, opportunistic testing in asymptomatic men or women, anyone with an STI, anyone with a genital lesion, and anyone with a rash. So, how do we diagnose syphilis? So the main form of diagnosis of syphilis is a blood test. And we have two types of blood test. We call them treponemal or non-treponemal. It's not as complicated as it sounds. The standard, high-sensitive, specific main diagnostic test is an EIA, CLIA, that's an enzyme-linked immunoassay, chemoluminescence immunoassay, EMIA, whatever it is, it's an automated, highly sensitive, specific test. There's a bunch of historic tests, TPPA, TPHA, they're just used to confirm them. And we've got another test which is called an RPR, which we use to determine whether or not patients got active or recent infection. We also have a couple of swab tests, a NAT test, which will tell you if the lesion in front of you is caused by Treponema pallidum. So if you've got a lesion, you'd like to know if it's caused by syphilis, you can do a NAT test and request that at the same time as a herpes test. It's important to know that these tests are not sufficient on their own to exclude infection. So if it's positive, it helps you in the diagnosis. But if you think you have a patient who might have syphilis, you need to do a blood test to determine if they do or don't. I'm just going to, sorry, it's a bit hard to point out without a pointer. I'm just, sorry, there was a pause while I was clicking the pointer and forgot that I was doing a webinar. So the EIA is the yellow test down the bottom. That is the main, there we go, thank you. I've got a pointer here. The EIA becomes positive soon after infection and will stay positive for the person's life. The RPR, which is represented as a titer or as a thing, will go up after the person is infected, will come down rapidly if the person's treated. If they're not treated, it will eventually peak and come down slowly. So we use the EIA to determine does the patient ever have syphilis, or have they ever had syphilis? And the RPR tells us whereabouts in the phase that it might be. So how to interpret syphilis serology? So we've got positive antibody test, EIA, CLIA. What we need to determine really is if the patient needs treatment or not, whether they need a single dose of benzathine penicillin, whether they need to be referred to hospital, or they need 3 weeks of benzathine penicillin. And to make that determination, we use additional information, previous test results, a documented or highly reliable history of treatment, and the RPR. So a patient with positive syphilis serology does not need treatment if they have a documented or highly reliable prior treatment history, the RPR is low, it means they don't have recent infection, and there's been no increase in the RPR since their last test. For any of these factors, if you are not sure, is absolutely defensible to treat the patient again and document it. Nobody will criticise you for retreating or over-treating a patient with syphilis. The treatment for syphilis that has definitely been acquired in the last 2 years is a single shot or 2 injections of benzathine penicillin. This is not benzyl penicillin, but benzathine penicillin. If the patient is seroconverted within the last 2 years, then they definitely only need a single shot. If you previously treated them and the RPR has been down, has gone down, but then has gone back up again, they only need that single shot. If you've got a very strong clinical suspicion of early infection, primary or secondary, a rising RPR, or positive skin PCR, then you can also treat them with a single shot. A patient who has any sort of CNS or cranial nerve involvement needs to go to hospital, have a lumbar puncture. A pregnant patient needs to go to hospital and and to be admitted and treated as an inpatient. And a patient with treatment failure, the RPR does not go down, needs to go to hospital. Everybody else and anybody you're not sure about needs weekly doses of benzathine penicillin on 3 scenarios, on 3 occasions, 7 days apart. So the treatment of...
Nick, just a question that we've had from someone. So when you're ordering serology, is it sufficient just to write syphilis serology?
Yes, you just write syphilis serology and the lab will work out which tests to do. They will automatically do the EIA test first. If it's negative, they will just issue a negative report. If it's positive, they will do confirmatory tests and an RPR.
Thanks so much. Yeah.
So the treatment for syphilis is benzathine penicillin, 1.8 grams, or it comes in 0.9 gram pre-filled syringes. So the patient needs 2 of those injections. They're large injections. They're given into each buttock, and it's done once a week for 3 occasions. So today, Wednesday night, next Wednesday, the Wednesday after, and then the patient is cured. A Jarisch-Herxheimer reaction, I mentioned that the organism can avoid immune control. Well, once you kill the organism, it loses that ability, and about 4 hours later, your patient will get sudden onset of fevers, sweats, joint pain, headache, and tachycardia. It's very common. It's alarming, but it's not serious. You should warn your patient about it so that they don't end up calling your after-hours service or dialing 000 or something. They can just go to bed, take a couple of paracetamol. If the patient's allergic to penicillin, they can be treated to doxycycline, and there's the schedule there. Clearly, if the patient's pregnant, they cannot be given doxycycline. If the patient's pregnant and penicillin allergic, they need to be desensitized. If the patient's given doxycycline, it's important to confirm their adherence. We repeat the serology at about 3 months to determine that the RPR has gone down. That's important to determine that the treatment's worked, and it also helps to diagnose reinfection at a later stage. Your patient can get syphilis as many times as they like. The EIA will stay positive for life. Once they've been treated for syphilis once, the only way you will determine whether or not they've been reinfected is that the RPR had gone down, will go back up again. Any patient who has been diagnosed for any STI, whether it's gonorrhea or chlamydia, needs to be tested for all STIs that I listed on the earlier slide. So increase syphilis testing in your practices. Beware of the patient of the rash. Just request syphilis serology. Use the RPR to monitor treatment and detect reinfection. If in doubt, treat.
Is there any point of care testing for syphilis?
Tonight we've talked about Medicare testable.
Yeah.
There is point of care testing available in project bases,
yeah.
But it's not available through Medicare billable testing on the whole.
Okay. So
it's project based.
Someone was asking about it.
It's very important in remote communities, this point of care testing.
Yeah. Okay.
Okay.
Sorry, just before you go on to this one. Someone had asked, I mean, they probably can check it, if someone did a biopsy on a secondary syphilis, what do you reckon they'll find?
The lab can often see the spirochetes.
In the biopsy?
It's a frequent, embarrassing scenario for a GP or a dermatologist. Odd-looking rash. Patients fail treatment with antifungals and topical corticosteroids for weeks and weeks. Eventually has a biopsy. The biopsy is bursting with spirochetes or shows some typical signs, and that's the point at which the syphilis is.
Okay.
Great. Our audience knows they're very impressive. Untreated genital gonorrhea infection. The correct treatment is in fact ceftriaxone 500 milligrams plus azithromycin 1 gram stat. I spent a little bit too much time talking about syphilis, so I'm going to have to increase my rate here. I'm sorry. I may have to dash over a couple of slides. Gonorrhea is also a bacterial infection of the mucous membranes, sexually transmitted, frequently causes asymptomatic infection, particularly pharyngeal and anorectal. Urethral infection in men is highly symptomatic usually. It's an increasingly important cause of pelvic inflammatory disease. Just a few years ago, less than 1% of cases of PID at Melbourne Sexual Health Centre were gonorrhea. Now it's more than 7%. It used to be restricted to MSM and travellers to Southeast Asia, but has now moved beyond these groups. And drug resistance is a very serious issue. This is your classic tip of the iceberg gonorrhea presentation, pus at the meatus or pus at the cervix. Most gonorrhea is asymptomatic. The only way we control gonorrhea in the population is testing asymptomatic individuals. NAT testing, almost always labs will do NAT, chlamydia and gonorrhea testing at the same time. Anorectal and pharyngeal specimens are essential in men who have sex with men. Now, this is a point I'd like to make here. We do not do bacterial culture as screening. So in asymptomatic individuals that we want to screen, we just do the NAT test. But if their NAT test is positive, you're going to be recalling your patient and treating them. And you should recall them and treat them on the same day. But if you would do us a favour and order a culture before you treat them, then you will help to detect the arrival of drug-resistant gonorrhea in our community. Currently, less than 30% of gonorrhea cases in Australia have a culture. So 70% just have a NAT testing. There's no information about drug sensitivity there. So that means that if there's a multi-drug resistant gonorrhea in Australia, there's a 70% chance that that person will be treated without a culture, and then that we will lose that opportunity to detect these cases. So by virtue of you spending your valuable spare time listening to me talk to you about STIs, you've indicated that you have some sort of special interest in STIs, and we certainly would like GPs and primary health doctors with a special interest in STIs to be doing this extra level of testing, which is a surveillance gonorrhea culture on the day that you treat the patient. If a patient is symptomatic or has a syndrome and you want to treat them on the day, those patients should have a culture taken on that day.
So one of our audience members had asked, are there any specific techniques to ensure with pharyngeal swabs to sort of increase the likelihood of positive predicted diagnosis?
So one of the advantages of the NAT testing is that it's much more sensitive. So it's certainly it's much less of an issue with NAT testing. The cultures are frequently negative from the pharyngeal. So you might do that culture and it might be negative. But contact with the retropharynx and both tonsillar fauces increases the rate. We've got very good data is that the more contact that with the tip of that swab with the back of the patient's throat, we're more likely to get some gonorrhea genetic material. I make my patients gag. Just a little bit. I think I've made these points. These are out of the guidelines. I should have put a poll in here. Do you notice anything new or different or unusual about this? I'll just mention that the guideline for uncomplicated pharyngeal infection has changed as of December from ceftriaxone plus 2 grams of azithromycin. The reason we use ceftriaxone plus azithromycin is to prevent the emergence of resistance. We believe that gonococci find it more difficult to be resistant to 2 organisms rather than 1, to 2 antibiotics rather than 1. Patients need to abstain for 7 days. You can do a proof of cure at 2 to 4 weeks, 4 weeks for a NAT test, 2 weeks for a culture. Good idea to retest at 3 months. Any patient with an STI needs to have a full STI screen. All gonorrhea is drug-resistant gonorrhea. This graph here shows that the years over the last century when different antibiotics have worked, we're on borrowed time with ceftriaxone. The fact that we're combining it with azithromycin in Australia is probably helping, but it will stop working at some point. And the best thing we can do for that is as gonorrhea cases rise, try to do cultures as often as possible so that when it stops working, we will know about it. That would be a great help to the public health. Key messages on gonorrhea, check your guidelines because they can change. Please increase gonorrhea testing, particularly 3-SAT testing and MSM, and do a culture before treating the patient.
So with sorry, I just missed that last bit. So how do you know that is it the NAT becomes clear? Do you retest?
Yeah, I said 2 to 4 weeks,
Sorry,
and I probably should have been a bit clear. The NAT test, because it's so sensitive, can be a bit slower to become negative.
Yeah.
So if you've had a positive culture, you can do the culture after 2 weeks.
Okay.
If you've had a positive NAT, you do the NAT after 4 weeks.
Okay, I think that answers the question that someone asked.
Yeah.
Thanks.
Just a couple of slides on Mycoplasma genitalium. It's a bacterial STI with some similarities in its clinical presentations to chlamydia. The evidence regarding the management is evolving, which is I guess a euphemism, rapidly changing. It's an established cause of urethritis, cervicitis, and pelvic inflammatory disease, and there are associations with preterm delivery and miscarriage. Drug resistance is very common, increasingly common, particularly in MSM, where it's well over 80%. Asymptomatic infection is common, but we don't know the significance of that, and we are absolutely not recommending asymptomatic screening because of the problems with treatment. As I said, it can cause a urethritis, a PID, a vaginal discharge. The test is via first pass urine in men or an endocervical or vaginal swab in women. We do not recommend screening of asymptomatic patients. We just don't have the data to suggest that we're doing people a favour. The commonest time in which people are getting tested for Mycoplasma genitalium are those with a symptomatic presentation of cervicitis, PID, urethritis or proctitis. In sexual health centres, that's often done at initial presentation. In a lot of settings, it's if a patient's got symptoms but is negative for gonorrhea, chlamydia, or has persistent symptoms. And contacts, we are testing for them. Treatment is problematic. When it's known to be sensitive, you can treat with doxycycline for 7 days, followed by azithromycin using this regimen. So we've got this very unusual two-step treatment where we use doxycycline for 7 days to reduce the bacterial load, and then we give an antibiotic that the organism is sensitive to after that. And that's either azithromycin or moxifloxacin, which is an off-license and non-PBS use of moxifloxacin. And if somebody's got pelvic inflammatory disease, we give moxifloxacin from the beginning for 14 days. Always do a test of cure for Mycoplasma genitalium. I think this might be my penultimate slide. Just about.
Some of the questions that we've been getting around contact tracing yes. and cover is people are interested in knowing things like, with things like chlamydia, syphilis, yep. Is it lab reporting or is the GP reporting, and with partner notification, who notifies whom, and what are the various strategies involved?
Sure. So for most common STIs, gonorrhea, chlamydia or syphilis, where there is no special concern, like patient's got a pregnant partner or something like that, then it's up to you and your patient to discuss partner notification. There is a public health and a medico-legal responsibility to document that. There certainly have been legal cases where people have said, nobody told me I needed to tell somebody. So you need to document that you've discussed it. The commonest outcome would the patient would contact their partner directly. And if the patient says that they will do that and you have no reason to disbelieve them, that is adequate in the vast majority of cases. There are a couple of websites which you've got in front of them. One is called letthemknow.org.au, which is for the general public, and the Drama Down Under is a sort of a gay-friendly website. And your patient, if there's people that they would like to notify but they feel a bit shy of doing it in person, they can go to this website and they can enter the patient's phone number or email address. There's a little drop-down list for the STI, syphilis, gonorrhea, chlamydia, whatever, and your patient's partner will receive an anonymous email or, so I should say an anonymous email or text message and a link to where they can get testing information. This service has been evaluated. There's been very little inappropriate and malicious use of it. Alternatively, if you really want to do it, you can do it with your patient on the computer during the consultation, if that's something that you want to do. If there are significant issues, for example, syphilis in a male with a pregnant partner or something where you think it's absolutely essential that you're able to confirm that the partner's been notified in treatment, then each health department will have partner notification officers, and it's usually available through their website that will assist you with if it's required. There was a question about notification. Usually there's both lab and clinician notification. The notification will still go ahead if you don't do it. It'll still be reported as a case, but whether the patient was gay or straight and whether they had the right treatment, that sort of stuff will be up to you to put on the notification form. Some issues really last take-home messages. Syphilis is rising rapidly and is a serious threat, particularly congenital syphilis. Increasing rates of screening of asymptomatic individuals is the only way to control syphilis in our community. Think syphilis with any genital, oral or anal skin lesion, any rash, particularly a rash that doesn't feel or look right. Consider increasing testing in women who might fall pregnant, male partners of women who might fall pregnant. So that's a fairly wide net. I do know that, but ultimately we're going to prevent congenital syphilis by creating a safe syphilis-free zone around pregnant women. Help us out with the detection of multi-drug resistance gonorrhea by doing a culture before treating a patient. So hope I've helped you with some aspects of the Australian STI Management Guidelines. We've discussed about STI screening and we've updated your knowledge on the treatment of syphilis and gonorrhea and Mycoplasma genitalium. So we've got a bit of time for additional questions and discussion.
And we've got a few. So one of the things, earlier on we talked about going back to, we were talking about opportunities for raising the topic of STI testing within the general practice setting. And women often present to their GP with, women's health issues and also around contraception requests and the like. What are some of the opportunities for raising opportunities with your male patients in the general practice setting? Any sort of strategies and tips that might help people in that situation?
So there's good evidence that that men will take up STI testing if it's offered to them.
Mm-hmm.
So I think even initiating a discussion, I think it really, to start with the discussion of STI testing, people are most comfortable with, even without discussing their sexual behaviour. So I think it's very reasonable to, for example, when you're taking some sort of preventive health history, like vaccination would be a common one to take it. Have you been vaccinated against hepatitis A and hepatitis B? When did you last have an STI test? That would be an easy way. That's a good hook.
Yep.
If it's been a while, could you? Can we do some tests today? Because we're asking people to consider STI syphilis testing, and that's a blood test. That is when somebody is having a blood test is a good time to add a syphilis blood test. Mm-hmm. That's an opportunistic one. Clearly, if someone's having a urine test, is a good time to have a gonorrhea or chlamydia test. A lot of patients are already habituated into having a chlamydia test. And somebody that you might give a chlamydia test to, it would be reasonable saying, well, now we're recommending testing for syphilis as well. Can we do a full STI test, including a blood test?
So another question that a few people asked, what's the role of hepatitis C serology in sexually transmissible infection screening?
So currently, Hep C testing is in the Australian HIV pre-exposure prophylaxis guidelines. So gay and bisexual men on PrEP are recommended to have Hep C screening once a year. HIV positive gay and bisexual men are recommended to Hep C screening, but for the general population, Hep C is not sexually transmissible, but there are overlapping risk factors. So people who inject drugs are more likely to have an STI as well as having Hep C. But strictly speaking, STI testing, Hep C is not recommended. It's just for STI testing.
Yeah. So obviously, if there's a history of exposure,
yeah, drug use and special populations where we know that Hep C is underdiagnosed. So in Aboriginal and Torres Strait Islander people, for example, we know that there's a much lower Hep C diagnosis rate. So you might do throw in a test in those situations on a one-off basis.
Another question that somebody had is in regards to syphilis serology testing. So someone's had a very recent exposure. I mean, an example of this would be maybe sexual assault. How long does it take for syphilis serology to?
So syphilis, the syphilis test is an antibody test. So like HIV, there is a window period during which time infection will occur, in which it takes some time to develop antibodies. Unlike HIV, the window period is not so precisely characterised. So by the time somebody's got a lesion, they've almost always got antibodies. But in terms of excluding infection, in which you can tell somebody who's been exposed they definitely don't have it, it's probably around the 6 to 8 week mark. Though people will often be positive within 2 or 3 weeks. Does that make sense?
Yes, that makes sense too. But I think it's important to keep in mind that there is that variation.
Yeah, and it's a different scenario. One is somebody who's been exposed, who's very worried and is traumatized, and when's the earliest time you can tell them they were definitely not infected? That's a quite long time. In terms of somebody who might be at risk or might have symptoms, how soon might you pick it up? It would be quite a bit sooner.
Yep. So somebody has asked the question, how to collect a sample for culture if there's no urethral discharge like in a man, but there might be a history of exposure in that situation.
So thank you for asking that question, because I didn't mention it. So on the whole, we ask you to repeat the test that was positive, except order a culture. So if it was a swab, a throat swab, an anal swab, a vaginal, cervical swab, if that was positive on the NAT test, just do that again, and this time it was order a culture. The vast majority of men with urethral gonorrhea are symptomatic, and you're probably going to be treating them on the day, and there usually is discharge. The rare cases of gonorrhea without discharge, I think you could probably be excused for not ordering a culture on that situation, or you could try the lab to do a culture from a first pass urine.
Yep.
You do not need to do a urethral insertion swab.
And someone has asked, I think it's because maybe it's something that they read in the guidelines. So if you've got a heterosexual female or male requests an STI check, do include gonorrhea. I think you would these days.
Yeah.
I believe the current guidelines just advise chlamydia as well as HIV, syphilis, and Hep B.
Yeah.
Mm.
So we are asking you tonight to add a gonorrhea test.
Yeah.
I'm not sure if particularly. I'll have a look at the guidelines.
Well, I think there's sometimes people get a bit confused because some of the college guidelines, particularly around the Red Book, talk about that, but they're just talking about asymptomatic screening. And the difference, if someone's requesting an STI check, and correct me if I'm wrong, from what you've said, they've straight away identified themselves probably as being at much higher risk. So they're not general population.
Yeah.
So the risk of detecting some positive infection actually probably statistically increases quite a lot.
And actually, we're in a bit of a state of flux with for example, the College Red Book Guidelines has got a recommendation for chlamydia screening for young women, for example, and there's risk-based assessments for other screens. But we are, between versions of guidelines, we're seeing rises in notifications. So I think there's awareness about having a low threshold for offering additional tests.
Yeah, that's fine. I think that's quite a. Just looking through some of the questions. If a patient is allergic to penicillin cephalosporin, what antibiotic can be used for gonorrhea? You said doxycycline. No, but that won't work. Sorry. What's the recommendation?
So, what we'll do is you need a culture in that situation, not before you treat them, but there are recommendations there. It depends on the site, but we usually give a larger dose of azithromycin would be the commonest situation. And there are recommendations about what the nature of the beta-lactam allergy was.
Yes. I think that covers most of the questions. Yep. Yes, that's.
Well, thank you, audience, for having so many questions.
Yeah, that's really good. There's been quite a lot of questions. There's more questions here, but you actually answered them as we went along. So, well, I think that's pretty well it at that point of time. There we are. So, this is your last opportunity to put questions down. Well, there's a few more actually. A few more just come in. I feel like I'm on a telephone here. Well, here we go. Sorry. If a female presents with intermenstrual bleeding and or postcoital bleeding, would you routinely advise testing for Mycoplasma genitalium as well as chlamydia and gonorrhea, and of course the cervical test?
Yeah, probably not.
No. Not in that situation. Again, yes, I think that's pretty well it. I think that's pretty well it in terms of. Well, so in that. So thanks so much, Nick, for giving this.
Yes, quickly some resources.
Yeah, so I was just going to think some of these resources that are available for people were available from ASHM. So can you just go through some of these?
Yeah, well, the guidelines we've mentioned. You'll have links for all of these. Australian STI guidelines. Bookmark them. I've mentioned about the. We've got a New South Wales Health have got a testing tool, an STI testing tool. They're the guidelines for asymptomatic men who have testing men who have sex with men. There's a link in the presentation actually to the specimen self-collection guideline instructions. We've got the Australian Contact Tracing Manual, that's Partner Notification Manual, and there's other resources there on ASHM. And if you want to look at a collection of dirty pictures, some of which you've seen tonight, you've got the MSHC STI Atlas there as well.
That's the Melbourne Sexual Health Centre.
Yes.
Yeah, okay. That's where it all happens. And these are also some important resources for patients. I think you talked about some of them already.
Yeah, so you can just write the patient this website down on a piece of paper or show the patient to them and ask them to Google it, and they can notify their partner using this. And there's, again, ASHM's got these all good websites with some multicultural and multi-language STI information at the All Good website.
Okay, so I think that wraps it up for tonight because we're rapidly running out of time, I think. So we'd like to thank Nick Nedlin for coming tonight to talk for his focus on STI testing in the general practice setting. And we'll have follow-up evaluation emails, is that right? So keep an eye out for those, and if you can really give us feedback, that would be really helpful. so we can improve these presentations, and also just for future presentations as well. So anything else there?
Thank you very much. Thanks for your attention.
Okay, and thanks very much for joining us tonight.